Hey, did you hear? Did you hear about the new podcast? Oi, what's it called? It's literally called Psst. There's a new podcast out right now. It's from Fil-CHA. Filipinx AO sharing stories together, as in the Psst podcast.
Hi, everyone. Welcome to another episode of the Filipinx AO Sharing Stories Together podcast. So today is Wednesday, July 14th. This is 10:30 a.m. here on the Pacific time zone, and we are now starting episode 6, the importance of data disaggregation, and research during COVID-19. So a quick disclaimer that information on today's episode is up to date as of today's recording. On July 14th, but due to the circumstances surrounding COVID-19, information may have changed by the time you view this episode. So before we get started, let's do some quick introductions. My name's Carlos Oronce. I am a primary care physician and a postdoctoral research fellow here at UCLA. Mike, why don't you introduce yourself?
Sure, I am Mike Nailat, also known as Producer Mike. I produce and co-host This Filipino American Life podcast, as you can see in my background. In my day job, I work on data, unsurprisingly, and also organizing the Filipino community. And thanks for having me.
Ninez?
Hey, thanks, Carlos. I'm Ninez Ponce, and some people call me Professor Ninez, Professor Ponce. I'm a professor at the Fielding School of Public Health at UCLA, and I also direct the Center for Health Policy Research, and I run a big survey called the California Health Interview Survey. Happy?
Good morning, magandang umaga sa inyong lahat. I'm Happy Araneta, Professor of Epidemiology at the University of California, San Diego. I have a background in infectious disease epidemiology, but currently work on type 2 diabetes among Filipino Americans.
Great. And I should say that this podcast was started by the Filipinx AO Community Health Association, of which Ninez is our current president and I'm president-elect. But I'd also like to take a moment and acknowledge the sponsors of this podcast. So a big thank you to the Association of Asian Pacific Community Health Organizations, or AAPCHO, for making this possible. We'd also like to thank the Walmart Foundation for their generous support of this podcast. And lastly, this podcast was produced in partnership with the We Can Do This campaign and the U.S. Department of Health and Human Services. So like I mentioned, today's episode is going to be discussing data disaggregation, and this follows our recent episode on the impact of COVID-19 on the Filipinx LGBTQ community. We've also covered mental health, as well as the vaccine and vaccine hesitance in the community. So in this episode, more specifically, we're going to get into the value of data, why it's so important, and what all this really means for equity, both equity in health, equity in resource allocation, especially as we're now kind of navigating this phase of the pandemic where the numbers are starting to go down, that there's some outbreaks happening across the country, but overall, I think a lot of us are feeling really optimistic. And so our guest speakers will help us understand these concepts, excuse me, what data disaggregation means, how does this pertain to COVID, and what this really means for our community. So Mike, I'll turn it over to you.
Yeah, and before we get too deep into the topic, because I know as someone who's really into data, once you get into it, you kind of just get into it, right? We're going to be talking about data about COVID, but data as it pertains to the Filipino community, and also data disaggregation. But, how did you guys get into data and research in the first place? I mean, I know for me, it was very much a desire to want to know more about my community, which is why I did both social sciences and Asian American studies at the same time in college. It was just a desire to be able to to tell that story from, I don't want to say from a statistical perspective, but to at least feel like I had more information that I could work with and share and educate people with in my own community. And so maybe starting with you, Ninez, what drew you to data and research?
Sure, thanks, Mike. I think, it's not the data itself that draws me because, data doesn't speak. It's the people who interpret it and the people who see it. So I was drawn to data specifically on data disaggregation on Asians and Native Hawaiian Pacific Islanders. It was one of my first jobs after my master's program in public policy. And it was very soon after there was a landmark report from the Department of Health and Human Services about, it's called the Black and Minority Health Report, that showed that there were disparities, and it showed that Asians in the aggregate had higher life expectancy than all other groups, including whites. And so it perpetuated this model minority myth. And this group called the it was called Asian American Health Forum, then it's now the Asian Pacific Islander American Health Forum. I was hired as their deputy director and data person to help with uncovering that story, digging deeper to kind of just demystify this aggregate category. And that's when I started getting into looking at census data, because the health data wasn't disaggregated, and just trying to give talks about how there was, the distribution of, there's a bimodal distribution of those that seem to be really doing well, but also a lot of the population's not doing so well. So it was a job. It was a job, and then it turned into a passion.
And how about you, Happy?
So my background in infectious disease epidemiology started with a pandemic that's familiar to most of us, and that's the HIV epidemic. And so as a master's of public health student at the time, it was perplexing why communities, men having sex with men, Haitians, intravenous drug users, and pregnant women were the most vulnerable populations at risk for HIV, with seemingly nothing in common. And so this goes back to the origins of epidemiology, the cholera outbreak in England, where data informed the geographical clusters of people who are at risk and informed where the contamination occurred. So then translating it to what I'm doing now in type 2 diabetes research, where Asians are perceived to have a low risk for type 2 diabetes, but my father, who was always, very thin, his mom, my grandmother, who was a dietitian, that side of the family had type 2 diabetes. So the discordance between Asians, are thin, they're at low risk for diabetes, contradicts with my personal history of high diabetes prevalence.
And so we've touched on it a little bit, but what does it look like to collect data on the Filipinx AO community in particular? Going back to you, Ninez, what does that situation or experience look like, just in general, before we really kind of get into the meat of that?
It's enjoyable. I mean, it can be done. So I don't know why more data producers and why they don't do it. Yeah, Filipino community in California is a number 2 after Chinese, number 3 nationally. It's sizable enough. We've had a long history in this country, probably the longest if you count Louisiana, right? And it's, we've contributed to the economy, to labor, to the healthcare industry. So it's it's representation of of people who contribute, make a living here in the United States. And so, so as a data collector, as a data producer from the California Health Interview Survey, we've been collecting data on Filipinos since it first started in 2001. Unfortunately, I think not all data custodians, data producers are as enthusiastic as I am.
How about for you, Happy?
So I agree with everything that Ninez said. I think in California, it's been feasible to report, and include Filipino category. We see that in census data. We see that in admissions data at universities. To me, but you don't see it consistently in hospital admissions. And so if we're relying on electronic medical records, that's an opportunity for patients to self-report, because when there are conditions that are informed by culture, behavior, diet, or even genetics, it becomes a necessary piece to understand, differences in pathophysiology.
Is California the only state that specifically calls out Filipino Americans within data collection, like the census or things like that? Or I guess it's like not the census, but I mean, I know that when I fill out certain forms for governmental things, like it'll ask, like, it'll say like Asian American, and then there'll be a call out for like Filipinos. Are there other communities or states that do that? I don't know if either of you know the answer to that.
Hawaii.
Yeah, California's interesting because there's state laws, particularly in the education space, that actually say Filipinos are separate from Asian. And I think they may have been from a long time ago. It was called Browns for Brown. And it was the first time Jerry Brown was governor. And there was a very strong contingent of Filipinos that really pushed for the separation of Filipinos from the Asian category. But I see in education statistics. And in health statistics, which is, kind of the world I inhabit, it's collected, but it's not necessarily reported.
If I can jump in here, we kind of talk like very broadly about health data, but like, and how, California is one of the few states, aside from Hawaii, that collects information on Filipinx health. Like, what does that mean? Like, what kinds of questions are asked? Like, what kinds of information is knowable about Filipinx health?
From nationally and from other places, do you mean?
Yeah, and CHIS, like what kinds of questions about health get asked?
So I'll talk about CHIS, and Happy can talk about some other data sources. So CHIS is the California Health Interview Survey, and apologies when I introduce myself. My pronouns are she, her, hers. So the survey is run annually, and we have questions on mental health, looking at psychological distress, suicide ideation. Do your emotions get in the way of doing routine activities, getting to work? And then we have questions on diabetes, which is definitely a problem. I know, Happy, I have diabetes in my genealogy. My godmother was one of Happy's research participants. So, and definitely I presented with Happy in other presentations, and she'd say, Dr. Ponce may look like she's thin, but she could actually be at risk for diabetes. So it's diabetes, asthma, hypertension, so we get at chronic conditions, non-communicable diseases. And of course, with the pandemic, we've added modules related to vaccine acceptability, getting tested for COVID, and non-pharmaceutical interventions, the safe distancing, the masking. So we do have that, and it can we can produce estimates. Now, we're each year, so sometimes estimates, and sorry, Mike, I'm gonna get into like the data wonkiness, but you have to like pool several years of data sometimes, like more than 1 year, to make sure that, the story you say is reliable, so it's more stable. So sometimes we do that. But I think a lot of this is what we know in health is it's also not just about these disease or illness outcomes, but it's all the the backstory of social opportunities that are unequal. And for Filipinos, we are, we do have those who are several generations here, those that are new immigrants. There's been more and more of low income immigrants coming here. Like, for example, when I first did the survey, we did not do Tagalog, and I got the heat from a lot of the Filipino community for not doing Tagalog. I mean, we do the survey in English, Spanish, Cantonese, Mandarin, Korean, and Vietnamese, because linguistic isolation wasn't a big deal, circa 2000. And then now it is. And so now we do the survey in Tagalog because it's a different wave of Filipino immigration. So we do ask about economic security and well-being, as well as food insecurity, and all the pain points and all the assets, though, as well, that ensure that there's resilience, or that systems ensure that there's resilience for the Filipino community.
So in my case, where I have a clinical cohort and they tend to be self-selected, so they're electing to participate in the study. There's also the multi-ethnic, and I have 600 Filipino men and women in my cohort. Hawaii has the multi-ethnic cohort with over 10,000 Filipino participants. But I think a very rich source of, almost population-based data include the Kaiser Northern California Permanente data. They were the ones who published one of the first diabetes articles with 800,000, with 88,000 Filipinos in their cohort. And so these electronic medical records, although it's based on eligibility for that specific insurance, becomes a rich alternative to population-based data.
And you kind of mentioned like we can learn about diabetes, we can learn about different health outcomes, psychological distress. And like as a researcher, like this is really, really important and fascinating. But from your perspective, why do you think this is important?
Carlos, why do you think it's important to assess health and the risk factors for health?
Mm-hmm.
Because particularly for we saw this during the pandemic. We saw that, and we'll talk about that more. I know Mike's going to steer us there at some point, but it's a fundamental right? I mean, health is a human right. It's a fundamental right, and also it's an investment. And I'm an economist, by the way, by training. So it's an investment in what's called human capital, which then leads to better workers, people more happy in jobs. And so, a more finely tuned, running well economy. So so health is a human right, and it's an investment in the well-being of an economy and a nation. And as we saw in the pandemic, health has what's called externalities, which means that with infectious disease, so your behaviors aren't just going to affect you, but it's going to affect other people. So if you don't get vaccinated, go to vaccine.gov, by the way. If you don't get vaccinated, then you're actually putting not just yourself at risk, but other people at risk. So because of this externalities of health, and it's really important to assess health, particularly also public health interventions.
And as we've seen in the last 17 months, without good health, the world becomes crippled economically. And so that's just fundamental. And with a highly contagious virus, if it were more lethal, for example, then I think it would be urgent to, the primary priority is prevention of transmission.
So yeah, let's start getting into it. Carlos, I know, we're going to start talking about data disaggregation. So you want to lead us into that conversation?
Yeah, I mean, why is like data disaggregation even important? I mean, like, and what does that even mean? And then as feel free to, I know you got a couple of slides that kind of touch on this, but feel free to jump in here.
Yeah, data disaggregation, I've told, folks I've spoken with, definitely my family, they have no idea what I'm talking about. It's not very sexy. It's not, I'm not a clinician. And I don't do actually the cool stuff that Happy does, with a cohort. Instead, I'm alone with my computer, looking at data and then trying to understand, what's the patterns and or requesting data, right? And so I think if you think about data disaggregation, fundamentally is about accurately getting at a person's identity, and identity that is associated with culture, associated with behaviors, associated with opportunities or barriers in achieving the best possible health, the best possible life, then it's a fundamental component of what we're calling health equity. So the measurement, the accurate measurement of race, ethnicity is, and also other dimensions, sexual orientation, gender identity, for example, that it allows then these disease detectives like Happy then to really understand what's going on, what the factors are, and what people need. And then for me, then it allows the presentation to policymakers then to deal with overlooking folks. And you hear this a lot now, is that if the data isn't disaggregated, then there's invisibility. And so if there's invisibility, there's no data, then there's no problem. So that's why, I mean, some of my relatives understand that, but they said, why don't you become a doctor like Dr. Oronce, as his patients?
Yeah. Yeah, so like it's important for, what you're saying is it's important for resource allocation. It's important for actually acting on, the health problems that we see. And it's this idea of visibility that, in our community, because we get lumped under Asians as a whole, that there's a lot of diversity, right? Like that this entire category of Asian somehow tries to capture these vastly different experiences, from people who are from South Asia to people who are coming from the Philippines, and all of our different stories and the reasons why certain families came to America and the circumstances that we've faced, in the US, and how that shapes our health.
Yeah. Yeah.
Did you want to?
Sorry, Happy, do you want to say something? Because I can actually quickly show one slide.
No, please do start your slides.
Okay, so let me just show some slides here. And I'm just gonna first start with this slide with what Carlos said about, the different groups. So these data are not for public use. They're not public facing. This is restricted data. And so again, to my point that and this is California data, and this is mortality statistics. So it's about death, not about cases, but it's about death. And I requested this last year, maybe August, September, and I didn't get it till late February of this year. So this is like a special ask it had to go, it's not, again, publicly facing. But what we were seeing, so this is all for 2020, is that the COVID-19 death rates on all Asians, which is what is presented in public facing data, was 74 deaths per 100,000, which is lower than the state total of 84 deaths per 100,000. So the policymaker and the observer of this would say, oh, it's lower than the state average. We don't even really, there's no unequal toll on Asians because it's a lower death rate. But when you get at those restricted data and look at, from South Asian, Japanese, Cambodian, Korean, Laotian, Hmong, Indonesian, Vietnamese, Thai, Bangladeshi, Chinese, Pakistani, Burmese, Taiwanese, that you see that the story unfolds of unmet need or this inattention because of aggregated data. And there's several groups that are over the 74 and several groups that are over the 84 deaths per 100,000 for the state. Yeah, so Filipinos are high up there. I would think they would, it's after Japanese and Cambodian, but this is for all ages. And sorry, Mike, do you mind if I just show? But here's a story for 18 to 64. This is of all Asian deaths. Filipinos made up 42% of the deaths.
Wow.
Asian deaths. But we never knew this. We didn't know that. Happy and I were in meetings, with the State Department of Public Health. They actually, Happy, have not released it yet. This is from same thing for 65 plus. Filipinos are high. So, and then this last slide, it's showing this what's called, are they disproportionately affected? And so you compare the percent of COVID deaths with the percent in the population. And here's Filipinos. So the blue line isn't good. The blue line is the share of deaths, and you're seeing, look at the high amount of the share of deaths compared to the share in the population, which is about 20%. So it's like about over 40% of deaths and only 20%. So this is just so much higher compared to, say, with Chinese, where it's the opposite. The share of population is higher and the share of deaths. But this story would not have been told. And although, Happy can talk about, we were detecting something was going on, but not from public health statistics in California and all other states, with the exception of Hawaii.
Those numbers are just so startling, just to see like that last picture that you showed where, the proportion of deaths, that Filipinos comprise out of all Asians in the state of California, I think was just flooring. And it's surprising that story hasn't been told. Like it's crazy that like among the four of us, like we're the ones that are talking about this, but like we're like, policymakers, public health people, like this story hasn't been told. And
I wonder if there's like a correlation with, frontliners, healthcare workers, or if there's some other factor, which maybe we'll get into in a little bit, but just like, why are those, why is it distributed that way across the different Asian, ethnic identities?
Yeah, absolutely. And Happy, jump in here.
Yeah, and I think that's why it's important to have these data to understand the why. So we're not all healthcare workers. And when what Ninez showed was, very rich data on among Filipinos in California, what proportion have died. That's the mortality rate. But when you look at among COVID cases, what proportion are dying? That's the case fatality rate, which suggests the severity of disease. It also implies who's being tested and who has access to healthcare. But even when we were looking at case fatality rates among Filipinos who are not healthcare workers, they were as high as 29%. And the trends that Ninez just showed were based on California. We have the largest Filipino population in California, but these trends are not unique to California. And I'm going to share some
please.
slides from Hawaii and, of all places, Manitoba, Canada, who have better surveillance than we do. Okay. Are you able to see this?
Yes.
So before the state shared California data, we were going up. So where were we getting information from obituaries? That is not the way to do public health surveillance. And the Los Angeles Times offered free obituaries to honor the deceased. And I was contacted by a reporter from the LA Times who noticed that there were so many that referred to this person died, was born in the Philippines. And she reached out and asked, why are we seeing so many COVID deaths among Filipinos? And about 3/4 were not healthcare workers. The other clue in the absence of disaggregated data came from contact tracers. So in San Diego, what they observed was after Spanish, Tagalog and Arabic were the most frequently requested languages. And so that's a tremendous error in public health surveillance systems if you are unable to identify who is in most urgent need of intervention. And this paper shows the invisibility of Asian Americans. So in San Diego, where I am, Filipinos are the second largest ethnic minority in San Diego. And when we're invisible, as Ninez mentioned, no data suggests no problem. We become ineligible for resources. It prevents timely and intentional interventions and continues to perpetuate health inequities. So here's another example. This is from Kaiser data, and this included 2 million participants. So just to emphasize, very similar to what Ninez showed with COVID data, when you lump all Asians aggregately, it looks like in this case, diabetes incidence among Asians are just slightly lower than the groups perceived to be at highest risk for diabetes. But if you disaggregate them, you'll appreciate that Filipinos, South Asians, and Pacific Islanders have a 50% higher incidence of diabetes compared to the groups that are perceived to be at highest risk: Latinos, African Americans, and Native Americans. And then just to show, very similar to what Ninez showed, where the proportion of Filipinos in California is about 25%, but the proportion of COVID deaths is 40%. This is Hawaii data, and it shows that among whites, they comprise 25% of Hawaii's population. In gray, you would expect the COVID deaths to also be 25%, and it's lower, it's 19%. So the only two groups where the COVID deaths exceed their share of the population are Pacific Islanders and Filipinos. So Filipinos comprise 18% of Hawaii's population, but 20% of all deaths. And in fact, the Filipinos in Hawaii have the largest number of deaths in the state. And it's not attributed to older age. So that's when data becomes necessary to understand, are they frontline workers? Do they have comorbidities that exacerbate their risk for death? Manitoba, Canada has published very rich data on COVID. And so in Manitoba, Canada, they have 83,000 Filipinos, and the infection COVID rates are ranked 4th, so highest among Southeast Asian, African, and South Asians, but then higher than the Canadian Indigenous communities, higher than Latinx, higher than Black, and higher than white Canadians in Manitoba. I wanted to emphasize this case fatality rate. So in California, as of 2 weeks ago, there have been 206,000 cases among Asians, and then these many deaths. So the case fatality rate is a reflection of the severity of disease. And this is not part of the national narrative. The case fatality rate in California is highest among Asians, followed by whites and blacks. It's the same pattern in Los Angeles. It's the same pattern in San Diego. And then globally, if you look, these are Filipino citizens who are residing outside of the Philippines. So the case fatality rates are, are consistent in all of the Americas, about 25%, consistent with the case fatality rate of California Filipinos who are not healthcare workers. But the case fatality rate in California generally is like 1.7%. If you have 100 COVID cases, 1.7 people will die. But the case fatality rates among Filipinos who live in the Middle East, who live in Europe, who live in the Americas exceeds the case fatality rate in California. So why are they dying? It's been established that selected comorbidities, including type 2 diabetes and hypertension, increase your risk of severe COVID disease and mortality. What do we know about these comorbidities among Filipinos? In 2016 data from Kaiser, among 1.4 million members who were over the ages of 45, showed that after Native Hawaiians and Pacific Islanders, Filipinos have the highest rates of type 2 diabetes, higher than the groups that are perceived to be at highest risk. I always quiz my medical students, name the 3 groups with the highest risk for diabetes. And they guess incorrectly. They say Latinx, African Americans, and Native Americans. It's actually these 3 groups. And then even among and because California has a large Asian American population, even when you disaggregate these groups, they also have higher diabetes prevalence compared to whites. And so this is why it's just so essential to look at disaggregated data, because this adds to the why, or at least justifies why we need to understand the why. Why is it that Vietnamese communities or women with 19-inch waistlines have higher diabetes risk compared to whites? With regards to hypertension, even as early as 36 years ago, this is the California Hypertension Study, it was established, back then, before this epidemic of, obesity that's more present now. So even 36 years ago, the rates of hypertension among Filipino women in pink and were higher compared to all other women, higher compared to Black women. And the rates of hypertension among men, Filipino men, were very similar to Black men. How does it look like now? This was from the Palo Alto Medical Foundation. So these are people who reside predominantly in the peninsula, Silicon Valley, and you see very similar patterns where hypertension prevalence among Filipino and Black men are quite similar. And then next to Black women, hypertension prevalence is second highest among Filipino women.
So this is both fascinating and very sobering. Because as you were going through all these different focus areas, I was just thinking about, well, I know a family member who has hypertension. I know a family member who has, or a couple who have diabetes. And I always think the data tells us, it gives us finer lines around the experiences that we already know. But I think what also is being highlighted here is the fact that we don't know really the extent or the proportionality of it until we really see the data, right? Like I just think like, oh, maybe that's just normal for people to know, half a dozen people with like diabetes. I know like more than a few people with gout, and isn't that just normal? Like, but I don't know, because we don't really get the chance to really dig into the data at that level. But yeah, every time we do, I mean, I've seen a couple other reports, less related to health and more related to kind of like economics and like housing and things like that, that show that Filipinos do not fit within kind of this very generic, either generalized Asian American group or even within like this perception of what that means to be with an Asian American, which is very much within some kind of like model minority framework, for in a number of different ways. So yeah, just being able to see that those numbers is a lot. And I guess in follow up to that, you know, what else are we missing? And with what we have now, you know, what can and should we be doing to really either dig into these numbers or really, you know, even just educate people? And either of you feel free to respond to that.
I think the other, I just wanted to say that apart from, you know, the risks of this, you know, the sobering data on that we have chronic conditions and multiple chronic conditions, that there's also on multi-generational households. I think that's also important. Families, very important to us. And so part of the transmission may have been through healthcare workers having higher exposure than going home, and in a multi-generational household where there could have been an older spouse or older father or grandfather. And so that's, I think that's again, part of that, that story on why, you know, why were Filipinos so hit. The other part is, you know, Mike, since your Asian American studies, is the colonial thinking and history. And there were stories from, you know, from LA Times, New York Times. There were just stories on nurses and how some of them had felt that they were not, they either didn't have the agency or they didn't feel they had the agency to ask about PPE, protective equipment, right? So, and also stories that it's you know, like masipag and matyaga, right? So you're like the first to go to, you know, you're hardworking, and so you're the first then to go to, you know, the front line. And one of our other colleagues have also, Jan Nazarino, Catherine Siniza Choi, and Alex Adia also published a paper that looked at nurses who were born in the Philippines tended to work in ICUs. So this exposure, but also perhaps thinking that they weren't, you know, first-class citizens in this setting may have also kind of led. So this is kind of part of the unspoken barriers that occur that may be, you know, not unique to Filipinos, but definitely in a you know, former colony, both in Spain and the U.S., and just also the culture of, you know, you do everything possible.
Yeah, and I think like just that, like it's like the knowledge gap due to a number of different factors, leading to kind of just like an engagement, a missed opportunity for like really kind of digging into, you know, are there things that I really need to be thinking about in terms of like my risk factors, my health, that might be unique to me because I'm Filipino American. And I mean, I don't think I even really thought about it other than like the fact that, look, okay, you know, there's a lot of Filipinos represented in the front lines. But it didn't really hit me until I think Affirm launched their Kalungan.net website that highlighted how, you know, Filipino frontliners were being disproportionately affected and dying from COVID. I mean, it's, again, as I was saying before, it was one of those things like intuitively, it's like, okay, this is what I would expect to see. But I think once you start really getting the data, you know, whether that's, you know, firsthand experiences, qualitative, really kind of understanding of what's happening, to kind of this detailed data that Happy shared with us, it's hard to really then know, you know, what it means to really kind of engage and wrestle with that. And then what do you do next, you know? I think on the flip side of that too, and this is maybe a wonky data person question, is, you know, sometimes I worry about like, do we have enough data? Like, are we making assumptions based upon really small sample sizes? I mean, there's a report sometimes I see when I look at like the N, and it's like, oh, it's like 24 like phone surveys. It's like, oh, is that really representative of our experiences? And so, is there a danger in not having enough data to really kind of draw these conclusions? And I guess on the flip side of that is, how do we get more data? What do we need to do to kind of get better information as we start to highlight these, these issues?
Happy, can I start with that?
Please.
Oh, thanks. So I think the way forward is that it's an opportunity for us right now to coalesce, to convene, and creating some kind of data hub or analytic resource. I know this is what Fil-CHA started, right? With just feeling very just frustrated about not being, by being invisible, not being visible in the COVID-19 data. So I think public health agencies, governments their role is to provide the best possible data for the surveillance of the population, and they let us down. So what happened? Social movements occurred. The obituaries, occurred. Kanlungan that affirmed, a big fan because they really elevated that something was going on that wasn't being seen in public health data systems. But to move forward, I think there should be some kind of data hub, an analytic resource on Filipinx AO, and where we are also looking at all the shared stories that get us to health, but also economic well-being. So focused on looking at institutional diasporic forces, that shape the health and well-being. So I think that would be a good investment from governments, from philanthropy. I know that there is a new Asian American foundation that just started. So I think would be a good one, or from Philippine philanthropy. The second is that it's, we want to grow networks. So to build evidence and communication space so that we can protect and elevate the Filipinx community, post COVID-19. So COVID-19 got us on alert, but we've got to continue to grow these networks. So there was a time when it really was just Happy and me on the academic scene in public health. I mean, I'm sure there were more, but I would always, it was us. And so we need to grow that network and grow, the next generation to continue, with this battle cry, right? Of please, build the evidence on the Filipinx community. And I guess the third is that, hoping that this gets seen by folks that are not deeply steeped in data or in public health policy, is that inform your community networks, that it is when there is a bill. So there's actually a bill right now in California and a bill in Congress, and where it's about data disaggregation, that it's actually a fundamental Bill of Rights. In some ways, data disaggregation is a kind of a Bill of Rights, right? So to get your communities, your titas, and to understand that, data is the disaggregation piece will really help with identifying what the unmet need is for the Filipinx community. So those are like my three things: a data hub, networks, and getting the word out in communities and decision makers.
I think what's needed in the immediate future is to address vaccination. We don't know what vaccination rates are like.
Yep.
After the Atlanta murders in March, what we noticed in San Diego was that overall vaccination rates were highest among Asians and Pacific Islanders. But if you look at the elderly, if you started to look at who was vaccinated among those 65 and older, it was lowest among Black and Asian and Pacific Islander elderly. Our concern then, especially with a lot of publications on anti-Asian unprovoked violence was, are our elderly sheltering in fear? And so grassroots movements like what Carlos and his group are doing to intentionally go to Filipino communities, vaccinate our elderly in safe spaces. We're doing that through mobile health clinics, also at churches, through UC San Diego Health. When I saw Ninez's slide about, the disproportionate number of deaths of Filipinos over the age of 65, I saw that with sadness, like they should have been vaccinated first, even before healthcare. Well, at the same time as healthcare workers. And I think the threat is still there. The Manitoba survey suggested that 75% of Filipinos in Manitoba were most likely to receive the vaccine. I got my vaccination at the Oakland Stadium where I had the opportunity to select Filipino as my race. I don't know if we have data yet on vaccine hesitancy, delay, or resistance or access in our community. So I think that's the most urgent need. I think there's also a lot of concern in the Philippines. My cousins don't want to take the Sinovac vaccine. So I don't know if they're informing their relatives here. I have a medical student who fights with his Lola on Facebook because she's so vaccine hesitant, and she does this publicly. So I think that's the immediate need now. I think the immediate need also in educating our community about how to continue to protect yourself with the variants that are evolving, and opportunities for treatment if there are monoclonal antibody centers in your area, to approach, if you're infected, treatments with hope.
Yeah, I mean, and I think we should take this moment to plug in. If you haven't had a chance to get vaccinated, you should go to vaccines.gov. If you want to find the closest place to get a vaccine, you can even text your zip code to 438829 or just call 1-800-232-0233. But as we were talking about vaccines, I was just thinking about how, as a kid, it just seemed like this normal part of being a kid, right? I had this card that had all these vaccines I was supposed to get, and there was this schedule, and especially for my parents too, because coming from the Philippines, all these conditions in terms of visiting and whenever they had to go back to the Philippines, there's all these. It was just kind of a part of making sure you were prepared and taking care of yourself. But as COVID came onto the scene and really just witnessing and observing people, in my family and people that I knew, have this completely different tack towards this. And part of it, I think, was just, the general hesitancy about anything, right? But it just differed from person to person in ways that I didn't expect. And I think part of it was just, we didn't have the data back then. And now that we had this data, I wonder how much of that would have changed perspectives, or at least led to better conversations about why in particular Filipinos need to think about vaccinations and think about their health in general. I think all of the things that you highlighted, Happy, just made me reflect on the fact that while like I was saying earlier, I know all these people who suffer from all these different conditions, I had never once thought, is that particular to my family and my community because we're Filipino? And is that something that I need to pay attention to myself as I grow older and think about I need to make sure I'm watching out for this being a possibility, because my identity might put me at higher risk possibly. So just a lot to really reflect on and think about as we get better data and more data.
Yeah, if I can jump in here, I think one of the things that I'm struck by is from Happy's slides, that we've known about some of these for such a long time. Some of the data was from the 1980s. And I'm wondering, why is this so difficult? Why is it so difficult to simply ask for data about our community? I'm starting to realize so this is what we mean when we say the absence of disaggregated data allows these problems to go addressed, and that perpetuates inequities. But like, why is this so hard?
I think it's hard because there's, again, we're running against this model minority myth. And so you're not shining a light on the need on Asians because we're under Asians. And so it's looked at as, okay, you know, there's when we talk about health disparities or health inequities, you saw the headlines, you see the articles, and it's, you know, Asians are not in that group. And then I think it's hard because there's no, I think that this is the moment with the attention on Asian, Native Hawaiian Pacific Islander hate, with Asian hate. I think this is the moment that, and again, this call for, you know, organization and social movement in the Filipino community to be demanding of better representation, to be demanding of visibility. In terms of the technical pieces, kind of like what Mike said, yeah, I mean, maybe data isn't going to be enough, but you should collect, and when it is possible to report, which it is, the sample side. I mean, there were a lot of dentists in the Filipino community. They could have reported it early in the pandemic. That there had to be better stewardship among the leaders, or demanding that stewardship among data producers to adhere to, like, fundamentally, what is public health surveillance about? It's to protect the population, you know, by presenting the high fidelity representation of that population.
I think in addition to that also is just, you know, the structural racism that's the foundation of medical education, where guidelines are informed by who participates in these NIH studies that inform the guidelines that you have to follow, Carlos. And so currently 86% of all participants in NIH studies are white. I think what you probably learned in medical school, Carlos, was that only obese people are at risk for diabetes. So those Asians are thin, nothing to worry about. And so I think that's when the medical education community needs to acknowledge the diversity in the United States, especially in a state like California. And we each have unique risk factors that exacerbate, you know, our risk for diabetes, for gout, especially. And so and just going back to what you mentioned, Mike, are these small surveys where the sample size is too small? Is that meaningful? I think it's an opportunity to raise that question. It's too small, so let's go larger. It's too small, so let's look at the next step. We actually started looking at uric acid levels because diabetes rates were so high. So a small survey leads to a larger survey, to broader questions of the whys.
Yeah, I can think of like 5 people off the top of my head. I'm not going to call them out, that have gout, and it's just like, I didn't realize how common it was, but also not realizing, like, is it actually common, or is it something specific to our community? We're starting to come up on our time, and there's so much more I want to know about and ask about, and maybe we can do some kind of like follow-up once we post this and make this more available to folks. But are there any specific takeaways other than the ones you might have already mentioned that you want people to walk away from this conversation with?
I'd like people to encourage checking the box that says Filipino, asking for a box that says Filipino. A lot of the LA data for Pacific Islanders was confounded by Filipinos reporting themselves as Pacific Islanders, or the LA Health Department reporting Filipinos, you know, collectively. So please use that as an opportunity to state and announce your identity. Get vaccinated, and stay on top of health education materials that you're able to share with your family and friends.
Yeah, I guess my takeaways are, again, more for the policymakers. So also in the checkoff in the box, if you check your Latino and Filipino, policymakers in California would put you as Latino, because as a Latino trumps all. And yes, there is this my girlfriends who I went to college with, they said, we're Asian? Like, I always check Pacific Island, Pacific Islander and then Filipino. So, so I think that, but I think that's the identity. So I think it's also more on the education of policymakers, data, epidemiologists, statisticians that have to deal with tabulating the data to, kind of consult with the groups that, you're generating the stories on, and the stories better be true.
This hour flew by, and this was such an amazing conversation. So I can't thank you both enough for being here. Happy and Ninez.
Yes, thank you.
This was incredible. For those out there who are listening, please, tune in to our next episode, episode 7, which is going to be on addressing COVID-19 misinformation. And our wonderful Lizel Tang Lao will be the internal host for that episode. Our external host will be Rochelle Ocampo, who's the producer and main co-host of Makilala TV. She's also involved with NAFA. Rochelle, we're incredibly happy that you'll be back as our external host, and our guest will be Jocelyn Estandian, who is working with the Los Angeles County Department of Public Health. And so thank you again to our guests. Make sure to everyone out there to follow us on social media at PhilXAO_CHA and like us on Facebook. Thank you again to AAPCHO, the Walmart Foundation, as well as We Can Do This campaign and the U.S. Department of Health and Human Services for making this podcast possible. Thank you.
Thank you.
Yeah.